Hi, my name is Olivia Priest, student number 1251343, subject peripheral mobilisations and advanced soft tissue techniques. My case study is a 19-year-old female footballer who 6 weeks ago had a surgery on a reconstruction ACL. Firstly, I will be taking my client through a walking gait. I'm taking my client through her walking gait. As soon as she walks in, I'll have a look at her face to see if she shows any signs of pain. Secondly, have a look at her pelvis to see if she has a pelvic tilt. Then I'll have a look at her knees to see if she's got knotted knees or board-legged, which is valgus or varus knees. I'll have a look at the patella itself to see if it's in the correct place. If it's slightly lifting, it could mean that her quad is a bit tight, which is bringing the patella up. Then I'm having a look at when she plants her foot to see if it's neutral. And if not, that could mean that one of her gastrocnemius muscles could be tight. Stop there. Okay, so just before palpation, I'm going to name the joint, the muscles, ligaments and tendons surrounding the knee area. So firstly, starting with the quads, the quad bulk, we've got the vastus medialis on the inside, the vastus intermedialis, so it's right at the centre of the quads, and the vastus lateralis, which is lateral. The big seat belt over the top of the quadriceps is called the rectus femoris. Not forgetting our IT band and TF belt as well, running lateral down the leg. So grouping our quads together, we have the quadriceps tendon that's running underneath the patella and attaches to the head of the tibia. And then we have the big tibia and the small fibula running right next to that. We have the MCL, which is the medial collateral ligament. We have the PCL, which is the posterior cruciate ligament. We'll have the LCL, which is the lateral collateral ligament, and the ACL, which we're looking at, is the anterior cruciate ligament. So our bursas, we have the two supra patellar bursas, we have the infrapatellar bursas as well, and we also have a popliteal bursa right next to that muscle at the back, posterior to the knee itself. Lift your knee up to 45, please. Thanks. So behind the knee, we've got the popliteus muscle, and we also have the popliteus bursa, which I mentioned before. There's also a cavity membrane as well behind the knee. Then down again. For palpation, I'm going to check, see if there's a difference in the quads, in the quad size itself. I'm going to have a feel of the quads as well, so if there's any physical differences. If the quads are tight, and if the quads are tight, it could be a sign, it could be a recurring injury. So say for example, as I've already mentioned before, if the quads are tight, it could be pulling the kneecap up, or say for example, if one of the quads are tight, as there's 4 of them, it could be pulling them in a different angle. They feel alright. Just doing a little apprehensive test, which is just gliding the kneecap side to side, and doing it on the other one as well, just for comparison. Seem alright. Now a patella tap test, and comparison with the other one. pretty good. I would do this to see if there's any diffusion underneath the kneecap, see if there's any fluid. If the patella was to move slightly, then it would indicate that there was some fluid, which could then turn into an injury or recurring injury. Could you lift your leg up to 45, please? Thank you. So, firstly, feeling the epicondyles, femoral epicondyles, then feeling the tibial tuberosity, the head of the tibia. Also feeling the back of the knee as well. See if there's any swelling at all there. There you go, thanks. Now checking if there's any heat present. Heat's a good indication of the muscle being inflamed. Also checking the other knee for comparison again, which looks alright. Okay, now taking the client through resistant. Okay, so just lift you, yeah, and then heel to bum again, but I'm going to resist, okay, so it'll be harder. Yep, so knee to bum. How does that feel? So, okay, and extend again. Okay, so, sorry, bend it slightly. Right, and then you're going to straighten it. Ready? Go. How's that? So, okay, thank you. Now, my client is going to do 2 functional tests. First test will be a squat. So I'd like you to please perform 3 squats, just slowly down and slowly back up again. Okay, keeping your eyes in front. So here I am looking for, firstly, the client's foot position to see if it's neutral, pronated or supinated. Then I'm going to have a look at the kneecaps to see where the patella moves when the squat occurs, to see if it moves in a certain angle. Is there any pain present?
Yeah.
Yeah. Also, I'll be checking here to see if there's any crepitus. And that's it. And as my client is squatting, to see if there's a pelvic tilt, shoulders are aligned. How's that?
So,
okay, the second functional test I'm going to ask my client to do is stand on one leg, and then after that we're going to try the other leg, the healthy leg, to see if there's any differences and to compare. So firstly, with your left leg, just stand and then just flex your knee up, please. Okay, so firstly I'm going to see our balance, pretty good balance. Then to see how she plants her foot, see what angle she plants her foot, if it's forward, slightly lateral, medial. I'm going to have a look at the patella itself, which seems to be pretty neutral, which is a good sign. And then have a look at the quad bulk to see if there's a difference in size, which there is, which is good. Again, having a look at the pelvic tilt to see if one size is higher than the other. So then you can switch over. So this is the healthy leg, but I'm doing this to compare. So again, having a look at the ankle joint and the knee, the hinge joint. The patella looks to be pretty good as well, and the quadricep bulk seems to be pretty similar as well, which is good. Third special test I'm going to do on a client is called the Laban's test, which tests the ACL. So if you just lift your leg up, please. So my left hand is going on the bottom of the calcaneus. My right hand is going in next to our medial quad. So I'm going to push the calcaneus medial to the body and the quad lateral to the body. Is there any pain? Yeah. How much?
A lot.
Right. Okay. So place it down. So as you can see, the client is in a lot of pain. So this test was successful, and it is the ACL that is the problem. So I'm going to provide my client with two soft tissue techniques. First one is going to be massage. I'm taking my jewellery off, and I've already washed my hands. So I am going to be massaging on the quad just to relieve some stress and tightness towards the quad bulk together. So starting off with some effleurage, which is simply just increasing the blood flow and the lymph. So how's that pressure? Is that alright? Yeah. So because this client is a footballer and it is common for tight quads, according to Ashley Mittor, I'll approximately do this for about 5 minutes just to make sure the quad is fully warmed up as such. And then I'll move on to a different kind of massage, pestrissage and deportment, which can include passing of the muscle, passing the weight, nipping it, which I'm doing now. I'm grabbing the muscle and physically lifting it up. And also use different parts of my body, such as my forearm. I could use my forearm for the quad because it is bigger surface area as well, and I can get more strength with my forearm as well, especially when my hands do get tired. I could roll my hand up into a fist and use my knuckles just for more intense massage. So as you can see here, I'm going up and down with the muscle, going with the fibres itself, because all I'm doing, I just wanted to relieve some tightness and some stress from the muscle. I don't want to go side to side because I'm not working on any scar tissue, and of course when you go side to side with healthy muscle, no scar tissue, it can cause some issues there. So I will approximately be massaging overall for about 30 minutes. After effleurage, I will move on to petrissage and deportment for about 10 minutes, 15 minutes, and then end with effleurage again for the last 5 minutes. How is that? Is that alright?
That's good.
So my second intervention is I'm going to use kinesio tape. So I've had to improvise here because I've got normal size tape. So I've got 2 pieces of small tape. So 3 pieces in total. So if you could lift up to 45 degrees, please. Thanks. So firstly, I'm going to put this around the knee. Add a good stretch. And take these off. and just leave the ends with no stretch at all. So I'm physically rubbing the tape to cause friction to help with sticking. Second piece of tape is going to go starting at the lateral side of the quad and coming right the way down to the tibia. So the end bits, no stretch. And my last piece of tape, doing exactly the same but at the other side of the knee. So starting off at the medial side of the quadricep and stretching to, again, the medial side of the tibia. Again, the ends with zero stretch. So I'm going to give all of them a good rub, as I've already said. This source of intervention approximately the client can use it up to 5 days, obviously depending on showering and stuff like that. Oily skin and moisturisers could obviously be under 5. However, I've thoroughly washed, especially the quad, before massage, because it does need to be put on clean skin, so no oils or anything like that. So I have gotten the massage literature from Ashley Mateo 2018, and I have gotten the taping literature of Stephen McLean 2017. So moving on to mobilisations now. The mobilisation I have chosen is the anterior glide. I have gotten literature from C. Grant 2018. This mobilisation increases knee extension. So firstly, I'm going to put my hand on the lateral malleolus and the bulk of the gastrocnemius. I'm going to distract, laterally rotate the tibia. How's that? So I have chosen this mobilisation because I know my client does suffer from an ACL injury from her reconstruction. As you can see, she was in some pain.